Dear audience, let me present my topic about antibiotic prophylaxis for ERCP. So in our gastroenterology unit, we do a lot of ERCP, a lot of endoscopic procedures, even ERCPs, and we want to help patients and to minimize the complications arise from it. So we looked into infections after ERCP. It's called cholangitis. And we asked the questions, if we use antibiotic prophylaxis before the procedure, can we prevent it? Our data shows that there's a clear tendency of the protective effect of antibiotic prophylaxis. However, it does not reach mathematical significance. So we should be cautious, and general utilization of antibiotics are not justified. And there's room for further research to find a specific population or procedure where we should use the prophylaxis. So my name is Kálmán Zsigmond, and I work at the Military Hospital of Budapest. My vision is to increase the safety of ERCP, and my mission to achieve that is to optimize patient preparation for ERCP through research. We have currently undergoing 2 projects. The first one is addressing the topic of antibiotic prophylaxis by a systematic review and meta-analysis. The second one is a study protocol in this field for randomized controlled trials. So the first project is investigating the safety and effectiveness of antibiotic prophylaxis for ERCP. ERCP is a high-risk procedure. It can have several complications, and one of them are being infections, especially cholangitis. It's the third most common complication of the ERCP procedure, and it can have several consequences. Its mortality can reach up to 10% if it progresses into sepsis. By current guidelines, we should use antibiotic prophylaxis for patients who are at high risk for infections, and it is not recommended before every routine ERCP. However, the data here remains controversial. So our aim was to investigate the significance of antibiotic prophylaxis for ERCP. The clinical question is similar. Does antibiotic prophylaxis decrease the infection after ERCP? The patients who are undergoing the procedure, the intervention is the prophylaxis. We compare it to no antibiotics or placebo. Our main outcome is cholangitis, and we addressed several secondary outcomes. And our hypothesis is that antibiotic prophylaxis decreases the risk of infections. So we did our search in 5 major databases, and after the selection process, we ended up with 14 eligible full-text articles. Let me present our main outcome, which is cholangitis. So on this first plot, you can see here in the right column the patients who are in the antibiotic arm, who got antibiotics before the ERCP compared to no antibiotics. The number of cholangitis is shown as even numbers. We analyzed 10 randomized controlled trials with around 2,000 patients. The heterogeneity is moderate to high, which can be accompanied to the differences of the diseases of the underlying populations and the differences in the ERCP procedures itself. The outcome is shown as a risk ratio, which is 0.58, which means that there's a 42% risk to reduction of cholangitis by using antibiotics. However, this does not reach mathematical significance. It's clinically relevant because as we can further reduce cholangitis, we can further reduce the complications arising from that. But probably due to the heterogeneity and the sample size, it did not reach the mathematical significance. Regarding our secondary outcomes, we have seen similar patterns. There's a tendency of risk reduction, but they are not significant. And there's no difference in mortality in the 2 groups between the antibiotic and the control arm. So regarding our strengths, we analyzed randomized controlled trials to aim for the highest level of evidence. This is so far the largest meta-analysis done in the field with around 2,000 patients. So we have also limitations, of course. the studies analyzed can be considered old, and they are like 30 years old, some studies, and we have observed a change in the technology and the indication of ERCP through the years. And there's really a reported data in these studies, so we could not assess probably subgroups to find the specific population who benefits the most. So in conclusion, antibiotic prophylaxis may reduce the risk of cholangitis after ERCP, but implications for practice, clinicians should only use antibiotic according to the guidelines to selected patients who are high risk for infections. And there's room for implication for research that we should try to find the specific subpopulation or treatment where antibiotic prophylaxis can be beneficial. As regarding the status of the project, we're currently in the manuscript writing phase, which will be finished soon. The second project is building on the first one, is investigating the effectiveness of antibiotic prophylaxis in patients with biliary obstruction undergoing ERCP, and it will be a study protocol for a randomized controlled trial. We are investigating cholangitis here too, and it's important to note why we are doing ERCP. It's because mainly we have biliary obstruction. So either it can be a benign reason, for example, bile duct stones, or a malignant reason, pancreatic carcinoma, cholangiocarcinoma is obstructing the bile duct. And through the years, like before 2000s, ERCP was used as a diagnostic tool and a therapeutic tool also. And as we got better in imaging, we have MRI, better CT, and endoscopic ultrasound. ERCP is really reserved for therapy, is an invasive procedure. And the randomized controlled trials, which we analyzed in our first project, came from this era, where ERCP was used as a diagnostic and a therapeutic tool also. So we want to investigate the significance of antibiotic prophylaxis for ERCP in well-selected patients with an indication for ERCP with biliary obstruction. So we would include adult patients with the biliary obstruction proven by abdominal ultrasound, CT, MRI, or endoscopic ultrasound, and we would exclude patients who got previous antibiotic therapy within 1 week, show sign of cholangitis, had undergone previous ERCP, are pregnant or are allergic to the antibiotic which we choose. So after we prepare our protocol, we will move further with the statisticians to the sample size calculation. So in summary, we want to finish our first project next month, and after that year, the second project too. I would like to finish with a quote from Abraham Lincoln, "Leave nothing for tomorrow which can be done today." Thank you very much for your attention.
Questions?
You were investigating systematic antibiotic therapy. Have you looked at topical antibiotic lavage after finishing the procedure?
Yes. When we put together the study, we came across some articles that put antibiotics in the contrast agents. There were really few, 1 or 2 studies, and they did have poor results. So we didn't go further to this path.
In your study, which antibiotic do you plan to use for the prophylaxis, and why? And how will you apply that?
Okay, so we have the plan to look the cultures which we took from the blood and the hemocultures retrospectively in the department, and with the help of the infectologists to choose the antibiotic which can be the best for preventive effect.
That leads on to my next question. Do you take bile from patients who do not have cholangitis, and do you culture those?
No, we don't.
So that's then the wrong strategy. It may be a suboptimal strategy to look at the cultures of patients who have got infected bile ducts, rather than patients who don't have one at the time of ERCP. Do you see what I'm saying? Because if you do an ERCP for a cholangitis, there's already a bug. If you do an ERCP for not a cholangitic, there may be a bug, which may be different from the one which causes cholangitis in the other group of patients.
Yes, you're correct, but to defend this strategy, that if we do the ERCP, we go in with our equipment. So if we analyze those bacteria which we came up after the ERCP, we want to prevent the infection caused by these bacteria. Of course, we cannot do anything.
If I want to be mean now, I would say then you have to culture your equipment. But that's very mean.
That's 100% sure.
That's very mean to say. I would suggest, yes, that's a good strategy to look at the microbiome of the bile of these patients to determine what the best medication or preventive antibiotic should be for these patients. But I would also suggest to look at previous antibiotic history. So, patients who have had repeated Helicobacter pylori eradication, they may respond differently to the antibiotic. I'm just saying things. Patients who have had multiple chest infections and recent antibiotics, they may have a different microbiome in causing cholangitis in their bile duct.
And also, if a patient with a cholangitis comes in primarily to our unit, then we tend to take some cultures from the blood, and we will have some information there.
I definitely would exclude all the cultures of the bile which are the result of complicated previous procedures. So community-acquired cholangitis bile cultures would do, I think, for the purpose of your study, but not bile cultures from obstructed bile ducts from obstructed plastic stents in malignant strictures. But I assume you're going to exclude patients with a previously operated or sphincterotomized papilla, and also you would exclude them from your culture.
Yes, we plan to do that.
Very interesting. I will look out for the results of that culture, because that's a very exciting topic. Any further questions?
Culturing or bile sampling will be part of your protocol in this antibiotic prophylaxis trial. It would be worth to check actually, because it would add some more information.
It would make sense, and it is in the guideline that if a patient has cholangitis,
you want to involve patients who doesn't have cholangitis, only bile duct obstruction, whatever the cause, pancreatic cancer or bile duct stone, whatever is it. Whatever is the reason of you want to involve those patients, as I understood correctly in your trial, right? So for those patients, I would
it would be good.
Would suggest to include that part, and also another consideration is the PPI use, proton pump inhibitory treatment of involved patients. So you might need to stratify the patients who are taking PPIs and who are not taking PPIs, because it also might change the microbiome of the duodenum, which is the origin of the bile duct infection, actually, mostly.
Thank you for the observation.
And one additional comment: if you find us, we can help you with results from non-cholangitic patients' bile culture, because our protocol is if you get into an obstructed bile duct, we take samples for culture, regardless of the clinical diagnosis of cholangitis. So even in cholestasis in patients who have not had previous procedure. So that may be helpful for the purposes of your study, because this is Budapest population or Hungarian
yes, not
population.
so far.
Same population you would look after.